Okay, next nervous system topic, nervous system infections. Now, basically, there's two main categories we want to be aware of: infections that affect the meninges and infections that affect the brain. So specifically, we're talking about meningitis and we're talking about encephalitis. Meningitis is most often going to be bacterial, whereas encephalitis, more often than not, is viral in origin. And a lot of the possibilities for nervous system infections are going to come from portals of entry. In other words, with any type of infection, there has to be a point of entry that most systems have defenses established for. But in cases where those defenses are interrupted or compromised, there may be a portal of entry created. If it's through the bloodstream, it's hematogenous. That's telling us it's coming through blood flow. May come from trauma to the involved tissues, primary injury. Could travel via cranial nerves. Or there could be a transfer between mom and fetus. In the case of meningitis, literally the inflammation of the meninges. And recall, when we're talking about the meninges, the innermost layer was the pia mater, the arachnoid, and the outermost dura mater. And these three layers will cover all of the central nervous system parenchyma, or tissues, the brain and the spinal cord. In the brain, the dura is made up of two separate layers, an inner and an outer layer. In the spinal cord, it's a single layer, but otherwise the three layers exist. And in the case of meningitis, we're talking about any sort of inflammation that affects those tissues. And it's the most common nervous system infection. And remember, we said that meningitis is usually bacterial. People who are going to be at risk for contacting meningitis are people that have that are so there's a higher risk in immunocompromised patients. So traditionally, we think about patients who've acquired immune deficiency, long-term corticosteroid, organ transplant, recipients, cancer patients, all examples of those who could be immunocompromised for any of those possible reasons and others. So, causes. Remember, we said most commonly bacterial. One of the most common bacteria that we're typically exposed to as humans is Streptococcus pneumoniae. And usually what happens is an infection in some other part of the body occurs, and the bacteria is allowed to escape through the bloodstream and travels along, or could travel along cranial nerves, or possibly be transmitted from sinuses to the cranial nerves, or from the ears to the cranial nerves. In either way, they're getting able to travel through atypical pathways, blood or nerves, to seed themselves within the meninges. So we'll say through blood or cranial nerves from infections at other sites in the body. So, for example, an earache or a sinus infection or an infection in some other part of the body that was carried by blood. A skull fracture. Where there's direct exposure from streptococcus that might be growing on the skin, under the scalp, or on the scalp, and not causing any harm when it's presented there. The thing about a meningitis situation is it's got a relatively high mortality rate. So it's a very serious infection. Mortality rate is 20 to 40% when we're talking about this particular bacteria. It's going to be slightly less than that in some other types of bacteria. For example, it's about 3 to 10% in Staphylococcus. So basically what's happening in this situation, bacteria targets most typically the pia and the arachnoid. And if it's able to penetrate into the subarachnoid space, then it's going to be able to travel throughout the entire central nervous system through the cerebral spinal fluid. So this and part of what's going to happen during the inflammatory response is that there's going to be inflammatory debris, fancy word, exudate. So some of that will be dead cells from white blood cells that have been phagocytosing and so on. And this inflammatory exudate can cause obstruction. The cerebral spinal fluid. And we know what happens if we obstruct cerebral spinal fluid. That can lead us to hydrocephalus, and we can have a scenario that presents with what's sometimes described as a classic triad. So you have a triad, you're looking at three things. And the classic triad with this type of meningitis is a headache with a fever, indicating the infection, okay, and the neck stiffness associated with meningitis, especially if it involves the cervical spine. But that's indicating that the meninges have become inflamed and they're tugging or restricted now in their mobility. That's also sometimes you'll see it in your readings as nuchal rigidity. Basically, nuchal rigidity is referring to neck stiffness, just another way to say the same thing. So this is described as the classic triad, but it only occurs about half the time. More typically, any two of the three present. I mean, half time, that's good. That's why it's a recognized clinical presentation. The concern is that that increase in intracranial pressure is going to lead to loss of consciousness that is described as being progressive and rapid. And this is where the mortality rate is so high. About 30% also present with seizures. Increased respiratory rates. And as far as the diagnosis goes, we have the so-called gold standard, which means that it's right far more often than it's wrong. Is a lumbar puncture. Not sure how aware you are of what a lumbar puncture entails, but basically this is testing the contents of the cerebral spinal fluid. Basically, most common is an insertion between L3 and L4. And the reason that they want to go below the level of L3 is because the spinal cord is no longer a solid mass of tissue. It's described as being a cauda equina. It's a series of nerve fibers there. So there's a lot less chance of creating injury to the spinal cord by injecting a bore at that level to try to retrieve a sample of the cerebral spinal fluid. Okay, it's imperative that the diagnosis and the treatment must be fast. And that's to prevent the poor prognosis. Specific antibacterials and corticosteroids are typically going to be first lines of defense. The corticosteroids are primarily going to be applied to prevent secondary injury for the most part. So corticosteroids are applied to minimize in the nervous system, the damage that occurs to the nervous system more often comes from the immune responses than it does from the presence of the bacteria. In other words, the inflammatory response creates the increased intracranial pressure more so than the bacterial population would. So the corticosteroids are applied to minimize the immune response in order to minimize inflammation, or at least modify the immune response to minimize that inflammation as best as possible. So what we're concerned about with the increased pressure causing injury to visual or hearing pathways, motor weakness, hydrocephalus, seizures, etc. So that's why the treatment has to be fast, and it has to be specific in terms of antibacterials. Too often we apply antibacterials that are general in nature and they won't be as effective. So that spinal tap, that lumbar puncture is crucial to getting an identification of the bacteria that would be involved here. Another consideration with respect to meningitis is education. It's, as healthcare providers especially, you want to emphasize prompt management of ear infections to prevent transmission along cranial nerve 8, sinusitis, where we might get transmission along one of the other nerves associated with the sinuses, the facial nerve, for example, or the trigeminal. And if a patient is dealing with pneumonia, then we're increasing the possibility of a bloodborne or blood-supplied hematogenous, that's probably the best way to pronounce it, pathway for the transmission, in this case, of the bacterial culture from the lungs to the brain, or central nervous system at least. So strict protocols in the central nervous system with respect to surgeries. Which is standard but needs to be adhered to. Central nervous system surgeries, because essentially the central nervous system is not well equipped to deal with bacterial or viral infections because it's got a blood-brain barrier that normally protects it from that sort of thing. Now, if we take a look at encephalitis, now we're talking about inflammation of the brain tissues. Fancy word for the brain tissues that are the active parts or the functional parts, is parenchyma. Parenchyma is the functional tissue of the brain, and stroma is a term that's often used for all the supporting tissues, connective tissues and epithelial tissues that might be part and parcel of the organ, but not the actual functional part of that organ. So remember, we said with encephalitis, it's most commonly going to be from a virus, herpes simplex type 1. West Nile virus is an example. So those are a couple of examples. Herpes simplex 2 can also ultimately lead to a central nervous system infection, but it's far less common, and that's otherwise associated with sexually transmitted diseases as far as what a source would be for that. And basically what we're talking about now, we can also have bacterial infections, fungal, or parasites, but these are going to be much more rare as far as that goes. So once the virus crosses the blood-brain barrier, so basically the mechanism is virus crosses the blood-brain barrier. Remember, the blood-brain barrier was made up of support cells in the central nervous system that create a filter. And the design of the filter is to let beneficial things from the blood supply access to the neurons and prevent non-beneficial things from access. So certain proteins that are known to be toxic, certain other elements and cells that would be otherwise interfere with nervous system function are going to be blocked by the blood-brain barrier. And it's normally a very effective barrier, keeping the environment around neurons in an optimum pH, in an optimum temperature, and an optimum environment from the standpoint of making oxygen and glucose available, but not too much else. So it's usually very good. And when viruses cross, that's probably a Nobel Prize waiting to be discovered here, because nobody's quite sure why sometimes a virus under specific conditions is able to cross a blood-brain barrier unless there's some obvious disturbance already. But basically the concern anytime we have a virus that crosses a blood-brain barrier in any viral infection, in fact, I'm going to just spend a minute here for us to understand a viral infection. So the first thing to recognize is a virus cannot survive without a host cell. So viruses kind of hijack the host cell's nucleus to alter the DNA, mRNA pathways. And when that happens, cell stops normal function. So we lose the function of that cell and begins viral replication. So the viral replication will initiate an inflammatory response or an immune response as best as possible. So you get a bit of a double whammy with a viral infection. This principle kind of applies to any kind of a viral infection. Loss of the normal function for that cell, and then viral replication that makes more virus that needs to then go out and find new host cells and is able to spread in this way. Now, most viral infections are somewhat self-limiting. Cells have the ability to put up defenses against the spread of a virus. So the infected cell can send out chemical messages to nearby cells that signal those nearby cells to build up their defenses against any kind of a viral invasion. So those were called interferons. But basically, if this infection is allowed to take hold within the nervous system, it's going to create virus replication, an inflammatory response, and it may lead to necrosis of the involved cells. It's most likely going to lead to necrosis of the involved cells because it's lost its integrity. Oftentimes what will happen is that cell will be generating so much virus, the virus accumulation will actually rupture the cell membrane of the host cell, and the virus is able to escape. But that cell, of course, has been destroyed in that process. So it crosses the blood-brain barrier. We get abnormal cell function. That's the host cell we're talking about. We get viral replication. And we get our inflammatory response. And that might also lead to bleeding and a hemorrhagic type of necrosis that's going to occur nearby. So that all of that is going to magnify what started off as a virus being able to cross that blood-brain barrier. So how's that going to present up in the brain in particular? It's going to take some time, so it will probably progress over a few days. Because it's an infection, there's often going to be fever. Because of the location, we expect a headache, possibly some seizures. If it's serious and it's allowed to progress, it may lead to confusion. Some people will even experience psychotic behaviors. They may hallucinate or hear voices, that kind of thing. The good news is death is rare. And that's mostly because these viral infections tend to be somewhat self-limiting. However, during the progression of the disease, progression of the exposure, it's kind of an emergency to try to treat. Like most viral infections, most of the time what we're trying to do is maximize the health of surrounding tissues, because as we've said with the viral infections, we've got mechanisms within our natural immune system that are designed to try to minimize the spread of a viral infection. So fluids are important. Manage the pain. Manage the seizures if they're present. Steroids can be given, particularly if there's an increase in intracranial pressure. But basically, that's what we're concerned with. Just to give you a couple of current scenarios, for example, with the West Nile virus, we know that they're transmitted by a vector. A vector is a living organism that has the ability to transfer a virus from one source to another. So mosquitoes are notorious for carrying the West Nile virus. You get bitten by a mosquito or a tick, and now the virus has been introduced to your body. The very young and the older are who's at most being most susceptible, mostly because the immune systems are less effective or less sensitive in the case of aging, less developed in the case of the very young. And again, the mechanism, like our previous example, is that this virus is able to cross the blood-brain barrier. So it behaves very similarly to the herpes simplex type 1, which can be transmitted in that case, the exposure comes from droplets from someone who's already carrying the virus. It typically lies dormant in a cranial nerve, usually cranial nerve 5, or possibly in our olfactory tracts, and then presents every so often with a weeping sore. If that sore is open, the contents of the sore are transmissible. So a cough, a sneeze, direct contact through kissing or contact in other ways can lead to transmission. West Nile is from a mosquito. The other one that I want to spend a couple of minutes on is the rabies virus, because it's been recently in the news. We're generally aware, or you may be aware, that a young girl passed away not too long, just within a week or so ago, from exposure to the rabies virus. So the rabies virus, again, is carried usually by a rabid animal. In Ontario, it's most commonly going to be transmitted by a bat, although it's still rare. Everybody, doesn't like bats very much, mostly because of that reputation. But basically what we know is that this is a virus that's going to be transmitted by someone who is already carrying that virus. So bats can carry the virus. It doesn't make them sick. Dogs or cats can carry the virus. It does make them sick. They will ultimately die, just the same way that a human will, although in rare cases, rabies can go dormant and then present itself when the immune system is weakened or challenged in some other way. Essentially, we describe the rabies virus as a neurotropic virus. And it's going to be transmitted typically from the saliva of an infected animal. So in this little girl's case, the parents knew that a bat had gotten into the bedroom of the child at nighttime when I think they were away on a vacation or something to that nature. They thoroughly inspected the child and couldn't find a scratch or a bite mark anywhere. So they assumed that she had not been bitten. And then several weeks later, she started to experience the symptoms of rabies. And once that starts, it's irreversible. So basically, we get transmission from saliva of an infected animal. And at the site of the wound, or really from the site of the wound, the virus is able to travel from the peripheral nervous system into the central nervous system via nerve tracts. And because we're going from peripheral to central, it's sometimes referred to as retrograde axonal transport. Once it's gotten into the central nervous system, It's going to be able to travel to other organs and systems through nerves. And it specifically likes to target the salivary glands, and other oral tissues. So this makes it very easy to be spread through what's sometimes described as projectile salivation. In other words, coughs and sneezes and those sorts of things are going to provide the saliva in a projectile manner and make contact with people at a distance from the person that's infected. So it's going to present a lot like the flu. So maybe a bit of a runny nose, a little bit of a fever, flushed, achy, those sorts of nondescript types of symptoms. So somebody's not going to think too much of that in the early going. But the concern is that it's going to progress. So once the cerebral pathology starts to present, you might see things like agitation, behavior changes, agitation, progresses to delirium. And like I said, in some cases, it may become dormant. It may present some of these symptoms and then just seem to go away. But if it's going to get activated, it may get activated at a later date, be totally unable to relate it to contact with a rabid animal at some point in their past because of that dormant phase. And the issue is typically once it's become symptomatic, it's irreversible. And it ultimately is going to lead to death. And that's what happened, unfortunately, with this young girl who didn't get even seen by the medical profession. So the treatment, because it is preventable, but only under certain circumstances, we've got a vaccine that's very specifically available. And it's applicable before or after exposure, but prior to symptomatology. So once the symptoms are presented, the prognosis is very, very poor. So this vaccine is available before or after an exposure. It's an intramuscular injection. And it requires 4 doses over about a 2-week period of time. And basically, it's a rabies immunoglobulin. In other words, it's antibodies for rabies. And if you talked when you discussed best types of immunity, this would be described as a passive type of immunity because it's an injection that's being introduced to the body and it's being introduced as an antibody. So it will not give you a memory component. So this is a treatment for a specific exposure and not a treatment that would build up antibodies naturally within your body upon and so prevent previous or subsequent exposures from being a problem. This is a per exposure type of treatment plan. So the lesson to be learned here is that any suspected to rabies should be treated with a vaccine. There are no contraindications. In other words, any kind of a side effect is extremely unlikely, virtually zero, and rabies is typically fatal. So the idea is get the vaccine. If you're not sure, I've had patients present to me, tell me a little story. They were away on a vacation at a cottage up north, and they woke up in the middle of the night because something was fluttering around, and sure enough, it was a bat. In my clinic, I was a chiropractor. I didn't typically have to deal with infections and those sorts of things. But this was a clear case where I said to this patient in no uncertain terms, get yourself over to the hospital, explain what's just happened the same way you just told me. And you got to get a vaccine into your body straight away. Bat bites are really small, and back scratches would be even smaller than that. So it's going to be very difficult to find it in lots of cases. So you don't want to err on the side of neglect. You want to make sure you deal with this in a fast way. Now, having said all that, prophylactic vaccines like what dogs and cats get, they get 2 or 3 or a little bit longer type of protection from that. But it's not exactly the same sort of medication in terms of what humans would get. So the idea of humans getting a prophylactic vaccine would only be recommended where there was high risk of exposure. Let's say you were a researcher that was studying bats in bat caves, you might get the rabies vaccine with that in mind because it'll give you some temporary protection. But understanding the concept that this particular vaccine is not like the mumps or measles vaccine that's designed to give you long-term, if not lifetime, protection from that kind of virus in particular. Okay, let's move on to spinal cord injuries. We've talked a lot about the brain and different effects within the Okay, now that I got everything working again, we're going to move on and talk about spinal cord injuries. Spinal cord SCI for an abbreviation. Nowadays, we know much more about spinal cord injuries. There's been a lot of research because they're relatively frequent. They're most common in younger adults and adolescents. Males have a 4-to-1 ratio over females for experiencing these kinds of injuries, most commonly related to motor vehicle accidents or gunshot wounds or falls from heights, including diving into water. Recreational accidents would be part of that. And basically what we're concerned about here is dealing with the primary injury from the cause and damage that's occurred at an acute basis, but preventing or minimizing the secondary injury as a result of that primary injury. So most common in younger populations, males much more than females, 4-to-1 in a ratio. Car accidents, recreational, accidents. So that's like diving or even recreational vehicles, ATVs and so on. Falls from some other mechanism would account for these too. So these are the types of people that would be at risk for this sort of thing. We're going to classify them by the level and the degree and the mechanism of injury. So for example, when we're talking about the levels may determine whether 2 or 4 limbs are going to be involved. The degree refers to whether there would be a complete or incomplete presentation. In other words, paresis versus paralysis, right-sided only versus left-sided only, or both. That sort of thing is what we're talking about there. And most often, from a mechanism of injury perspective, so it's going to result in pressure being applied to a part of the spinal cord from a bone fracture or from bleeding into the soft tissues. As we've discussed many times, the nervous tissue is very susceptible to those kinds of pressures. So basically, these are the sort of present sort of mechanisms of injury to the spinal cord. The trauma can be relatively mild and somewhat reversible. Trauma can cause a contusion, but it may be as serious as a transection of the nervous tissue. So contusion, a little bruise, typically going to be reversible. So there may be some symptoms even of paralysis, but become reversible. But a transection is the extreme of that trauma of the nervous tissue, and that's going to be irreversible. Again, nervous tissue does not have a very good ability to regenerate itself, so injury results in replacement. Replacement is not conductive or excitable, so you've lost transmission pathways. Remember, the spinal cord is about sensory information coming in to the spinal cord, motor information coming out. So if the spinal cord is sort of simply visualized as being the highway carrying sensory information to the brain and motor information from the brain, we've lost that highway. So depending where and how much is going to determine the presentation. So when we talk about how this damage might occur, the mechanisms include hyperflexion, hyperextension, injuries. These are usually pretty devastating because they result in widespread axon damage. So there's going to be a severe loss of nervous system function as a result of this kind of movement that occurs within the nervous system. Compression can be more variable. So we'll just say concern is axonal injury preventing transmission. So, as we've mentioned, primary injury is the immediate trauma to the spinal cord. So this might come from that hyperflexion, hyperextension type injury that causes immediate axonal injury. And that might also result in neuronal death from compression, severe compression. For example, fragments of bone tissue that embeds itself within the spinal cord will cause neuronal cell death. And the secondary injury we're concerned about is how the body responds to that primary injury. So we're talking about the inflammatory response. We're talking about ischemia. And we know that those things lead to topics that we've already talked about: cytotoxic edema, white blood cell activation, neurotransmitter excitotoxicity, free radical, we'll call it accumulation. And we'll just throw in some et ceteras in there because a lot of it becomes progressive. So again, a lot of this is going to be summarized as neuronal apoptosis beyond the site of primary injury. Autoregulation of blood flow is going to be lost, or it can be lost depending on the location. And as a result of that, blood pressure can drop, and that's going to promote more ischemia. So it starts to look a little bit like a vicious cycle or positive feedback, one thing leading to another that promotes or accelerates the original stimulus. If we have interrupted blood flow, loss of regulation for blood flow, so we don't get the proper responses to that interruption, blood pressure drops, that causes ischemia. The original problem was ischemia, vicious cycle. So, signs and symptoms of somebody with a spinal cord injury. We can have complete or expect complete loss of function below the level of injury. Okay, before we know the degree of injury, That's what we expect initially. And it's otherwise described as being spinal shock. So in spinal shock, because of a compression, any other type of injury that might occur, there's going to be an interruption in function below the level of that injury. So it can appear worse. Because the spinal shock is a bit protective in nature. So it's designed to minimize ATP demand in order for repair processes to be better integrated or implemented. So it can appear worse than it is and can last from a few hours to a few weeks. So that's what we're talking about when we talk about this spinal shock. It may last from hours to weeks. And it'll present a little bit like this below the injury. We would expect to see flaccid paralysis. So that means the skeletal muscles have no muscle tone. They're unable to contract, they're unable to support, they're flaccid. Reflexes would be absent. Remember, reflexes are these are spinal cord reflexes specifically. So they involve a sensory pathway and a motor pathway. So these spinal reflexes would be absent. There would be no expected pain sensation. No awareness of where body parts are in space, proprioception, which is another type of sensory input. We would have abnormal bowel and bladder responses. So it wouldn't be a question of them being absent. They may evacuate with no sensation or no control. And no thermal regulation. Once the spinal reflexes return, it's described then as the end of spinal shock. Spinal shock is over when spinal reflexes So that's what defines the end of spinal shock. Now, sometimes your reflexes may not be restored, and that's indicating a more serious and more permanent type of spinal cord injury. You're often going to see spastic paraplegia or quadriplegia. So these are uncoordinated contraction, relaxation cycles that occur in an uncontrolled kind of way. Hyperreflexia. You get an abnormal extensor plantar response, you know, that maybe the so-called Babinski's response or plantar extension response in a baby. It's going to present itself the same way it would in a spinal cord injury, that we expect to see with a plantar reflex. We expect to see your toes to curl, flex, and in a Babinski's reflex or in a spinal cord injury, we see the big toe in particular extend, indication of a spinal cord injury. Bladder bowel will regain some of their reflex function typically over time, but can also see a situation where there's some flaccid paralysis as well. So these are just other presentations that can come from these spinal cord injuries. Another feature to be aware of when we talk about injuries to the spinal cord is what's referred to as neurogenic shock. Neurogenic shock occurs when the cervical or the upper thoracic neurons are injured. And because there's association here with the reflex centers of the brainstem, then there can be what's called the result of neurogenic shock can lead to distributive shock. So basically what we're saying is if it's brainstem, that's where cardio and respiratory regulation is coming from, the basics for it. If it's a little higher up in the hypothalamus, we may lose contribution of the autonomic nervous system with appropriate responses. So normally if blood pressure was low, which it would be in distributive shock, we'd expect a sympathetic response. If the hypothalamus is part of the pathology, then we're going to get an inappropriate or absent sympathetic response. If we don't have a good sympathetic response, blood pressure is going to remain low because of the widespread vasodilation caused from distributive shock. Decreased heart rate becomes life-threatening. There's something to be aware of with respect to spinal cord injuries that any healthcare provider should be aware of. It's described as autonomic dysreflexia. So you can tell a couple of things in that terminology. Autonomic is going to have something to do with the autonomic nervous system, and there's irregular reflex action going on. So this is often chronic in spinal cord injuries, especially upper, above T6, above the thoracic vertebrae, between the shoulder blades, essentially. That's what we're talking about there. So this can occur anytime after an injury and is life-threatening. So basically, it presents with a number of mechanisms that make it life-threatening. There's going to be sudden hypertension that's going to present with some headaches, but with a decrease in heart rate. The upper body will appear flushed and the lower body constricted, so pale, with sweating. So it presents signs and symptoms: sudden hypertension, headache, decreased heart rate. This is where it starts to fall apart in terms of what you would expect. And upper body flushing. So in other words, that's vasodilation, but lower body is pale, vasoconstriction, and sweating. Okay, so this is autonomic dysreflexia. So the mechanism goes like this. And you know I like asking questions about mechanisms. So basically what starts everything, what gets everything going is that there's a stimulation of the afferent, remember afferent heading towards the central nervous system, pain receptors. And remember, receptors are part of the peripheral nervous system. So we should be comfortable with the direction of signaling here. Okay, and this is happening below the level of injury. So what might cause a pain signal? A full bladder or constipation, right? That the patient might not otherwise be aware of, but at the nervous system level, that stretch and tension on those tissues is going to initiate pain receptors. So it doesn't have to be from an obvious source like an injury. It's going to be from a full bladder or constipation. So the pain signal is peripheral, but it's not going to get delivered all the way up into the cerebral hemispheres where you're going to become conscious of that. Instead, what's going to happen is it's going to initiate an increase in the sympathetic nervous system response and reflex vasoconstriction below the level of injury. So remember, during a sympathetic response, we're going to get vasoconstriction with the goal of trying to increase blood pressure. So we get overall vasoconstriction. So this part is what we would expect in response to pain. And that goal was to increase blood pressure. So what happens when we increase blood pressure? The increased blood pressure stimulates baroreceptors, pressure receptors in blood vessels, to respond, and their purpose will be to regulate blood pressure. So what's going to happen is we're going to get a decrease in heart rate, and we're going to get vasodilation of blood vessels above the site of injury. Can't get it below because there's no pathway to go below. So upper body flushes because of the vasodilation. Lower body remains constricted because of the sympathetic response. So there's a difference in physical appearance. Okay, and basically what we're saying is the descending pathways can't pass the injury site. So there's no inhibition of the sympathetic nervous system below the injury. No feedback. So in fact, the signal will continue, and this will become a vicious cycle, and eventually leads to such an imbalance that it's going to become life-threatening. So how do we treat this? Or how do we treat spinal cord injuries in order to avoid this in the first place? First thing right to consider is we've got to correct the cause. And that may require, because the initial injury, the primary injury, is irreversible. So we stabilize to prevent further injury. And anybody who's ever taken first aid knows what that entails, right? Limiting movement of the cervical spine, and all that sort of thing. So that stabilization may initially be external in the first aid sort of scenario, and eventually internal with some surgical stabilization with rods and screws and so on, in order to try to prevent additional injury. Compression on the spinal cord must be addressed because that is the source of the injury, and corrected within 24 hours to minimize progressive damage, secondary injury. So this during a neurogenic shock, the patient needs intensive care. They're going to need oxygen therapy, need O2, need blood pressure, probably need to consider thermal regulation. I've got regulation already in there. That's why I was hesitating on that. But basically, we need O2 regulation, blood pressure regulation, temperature regulation. Cryotherapy is therapy with cold. Lots of attention in the last decade or so has been addressed towards the role that cryotherapy might play in spinal cord injuries. Cryotherapy or cold therapy is described as being neuroprotective. And it's going to be applied in order to minimize secondary injury. The decreased temperature is going to give us lots of advantages. One thing we know, that if we decrease the temperature, we decrease ATP demand. We decrease metabolism, which means we're decreasing ATP demand. So less ATP, less work, less concern about the reduced amount of oxygen and glucose that may be being delivered to this compressed area of the spine. We know that the cold temperatures also regulate or inhibit inflammation. Cryotherapy is also helpful with respect to reducing pain. So your patient's going to be more comfortable. The pain responses and the risk for autonomic dysreflexia will be reduced a little bit. The drop temperatures decrease free radical formation. That we know is helpful. And we also know that a decrease in temperature will decrease excitotoxicity from amino acids. one of the other things we can throw in here, we might as well, is it increases blood-brain barrier efficacy. So in other words, it'll improve the barrier function of that blood-brain barrier, which applies to the spinal cord in addition to the brain. So basically the mechanism here for cryotherapy is the introduction of chilled saline to tissues around the spinal cord. Now, the thing that makes this a bit controversial is too cold is detrimental. We know that in the cases of hypothermia, there's an increased risk for cardiac dysrhythmia and respiratory abnormalities and coagulation of blood and so on and so forth. So it's a tricky balance between trying to establish those advantages, those 5 or 6 advantages that we listed, against the detrimental effects of cardiac dysrhythmias, respiratory pathology, or coagulation. So that's a balance that we have to consider. Chronic complications with respect to the spinal cord are going to leave us with some spasticity, some contractures, where again, if the patient isn't receiving regular physical therapy, the muscles will begin to contract. Often flexors contract over extensors so that the hips and the knees will be in flexed positions. The elbows and the wrists will develop contractures in the flexed positions. There's increased risk for spinal cord patients for respiratory and urinary tract infections, skin pressure sores, fecal impaction. Those sorts of complications are always concerns for someone who's got a spinal cord injury that is left with some permanent disability.